Now I will discuss about the RGU and MCU, including IVU, intravenous urography, retrograde urography, and micturating urography. Intravenous urography, that is IVU, is also called excretory urography, that is EU, is a radiographic study of the renal parenchyma, pelvic calyceal system, ureter, and urinary bladder. This exam has been largely replaced by CT urography. So, what are the indications of the IVU? To see the anatomy and physiology of the urinary system. Trauma calculi, that is renal, ureteric, bladder. Renal and ureteric calculi, particularly prior to the endourological procedure, and renal colic and loin pain. Congenital anomalies like ectopic kidney, horseshoe kidney, renal agenesis. Infective pathology, recurrent urinary tract infection, complex urinary tract infection, including tuberculosis, renal tumor, persistent or frank hematuria, renal hypertension, ureteric fistula and strictures, bladder pathology, that is diverticula and fistula, vesico-ureteric reflux. These are all the indications. So basically, to see the anatomy and physiology of the urinary system, if trauma, then we can see evaluate the structures, then calculi, then congenital anomaly, infectious pathology, then persistent or frank hematuria, and there is also tumor, and fistula, strictures, blood pathology, diverticula and fistula, and vesico-ureteric fistula, reflux. What are the contraindications? The first contraindication is if patient having history of hypersensitivity reaction, if patient is pregnant, if patient having renal insufficiency, hepatorenal syndrome, thyrotoxicosis, it is contraindicated in pregnancy, and it allows after 28 days after childbirth. Patient with impaired renal function, particularly those with diabetes, should be prepared with oral or IV hydration, or an alternative imaging modality should be considered. Then imaging anatomy on IVU. The kidney. It takes approximately 12 to 20 seconds for contrast to reach the renal arteries following its intravenous injection. At this stage, its concentration is maximum in the vascular compartment. However, this falls rapidly as the contrast medium begins to escape into the extracellular compartment, and also undergoes rapid glomerular filtration and enters the renal tubules. In the first minute of IVU, healthy kidneys, assuming a normal cardiovascular system, shows diffuse enhancement within 1 minute. This is referred to as nephrogram. It extends from the T12 to L3 level, vertebral level. Right kidney is slightly lower than the left. During the nephrogram phase, renal size usually at least 3 vertebra in length, and but no more than 4, or approximately 3.5 vertebral bodies in height. And outlines are best seen, that is in nephrogram phase. Its outline is best seen roughly in the first half minute of nephrogram phase, when contrast in the vascular compartment predominates and the cortex opacifies more than medulla in the first half, that is 30 seconds. This differentiation is sometimes visible on the immediate film of the IVU series, but regularly visible on CT performed at this stage. In the second half minute, that is next 30 to 60 seconds, contrast in the tubules increases and opacification of the kidneys is more diffuse. Contrast begins to appear in the calyces from around 1.5 minutes and it is provided that in the debit turn according to replace 1 minute. So in the second half minute, contrast in the tubules increases and opacification of kidney is more diffuse. Contrast begins to appear in the calyces from around 1.5 minute, or you can say 1 minute. From this time, in good quality film, contrast may also be visible in the collecting ducts as fine opacities running along the medullary pyramid towards the calyces. This may be referred to as a pilotubular stasis, or when less defined as the medullary or pyramid plus, and is a normal phenomenon. Contrast in the normal calyces will begin to drain immediately into the pelvis and ureter, and this phase may be referred to as pyelogram. So after 1 minute, pyelogram phase starts. Achieved at 5 minutes, it is achieved on 5 minutes. The successful application of compression impedes ureteric drainage and distance the pelvic calyceal system. So there is abdominal compression is applied. There is one on the both side of the rail. There is compressor and which is tight, or also we can use any type of cloth to compress the abdomen, so that there will be opacification of the collecting system, that is the renal pelvis and part of the ureter. Achieved at the 5 minutes, the successful application of compression impedes ureteric drainage and distance the pelvic calyceal system, producing optimal visualization of the pelvic calyceal system around 12 to 15 minutes. So it is saying that pelvic calyceal system will be completely visualized by 15 minutes, 12 to 15 minutes, and it varies. So basically 15 minutes. Minor and major calyces are connected to the pelvis by long or short infundibuli. The conical papillae indent the calyces with surrounding sharp furnaces. Ureter. After compression is released, there is a transient increase in flow down the ureters, and the released film offers the best chance of demonstrating the ureter. So just after releasing compression, we have to take the urethrograph phase. So the normal ureter exhibit continuous peristalsis, and on a single film it is uncommon to demonstrate the entire length of both ureter or even either ureters. They will often demonstrate smoothly narrowed areas, especially at the pelvic ureteric junction as they cross the iliac vessels in the pelvic brim at the vascular junction and more relaxed capacious areas. This is normal, and how vigorously further efforts are made to demonstrate the entire length of the ureter depends on the clinical situation. In most situations, partial visualization of a non-obstructed but otherwise normal ureter is acceptable. If there is persistent hematuria or abnormal cytology, further efforts to demonstrate the ureter are required and may include prone films, a repeat IVU after a short interval, and or retrograde pyelography. Course of the ureter. Abdominal part of the ureter begins from the pelvic ureteric junction at the level of the lower end of the corresponding kidney. It passes in front of the tip of transverse process of all the lumbar vertebra. It enters the pelvic cavity, passing in front of the sacroiliac joint, then along the anterior margin of the greater sciatic foramen notch, and reaches at the level of the ischial spine. Then it passes forward and medially and reaches the base of the urinary bladder. Urinary bladder. The corrugation of bladder wall are seen. The smooth impression of the uterus may be seen posterior superiorly in female, and the prostatic impression is seen inferiorly in a male. IV procedure, that is contrast media. Low osmolar contrast media, LOCM, there are 300-370 mg iodine per ml. Iopamidol USP, non-ionic water soluble. Injection amidol 370 equivalent to 370 mg iodine per ml. Adult dose 50 to 100 ml. According to David Saturn, 50 ml of 350 to 370 strength water soluble contrast. Pediatric dose is 1 ml per kg. Intravenous contrast is given relatively rapidly by hand. Equipment: any standard radiographic unit is suitable to perform the procedure. High power X-ray generator. Immobilization hand is usually not applied because the resultant pressure may interfere with the passage of the fluid through the ureters and may also cause distortion of the canal. However, the compression band is sometimes applied over the distal end of the ureter to retard the flow of the opacified urine into the bladder to ensure adequate filling of renal pelvis and calyces. Patient preparation: NPO for 5 hours, according to David Saturn 2 to 4 hours prior to examination. Patient should preferably be ambulant for 2 hours prior to examination to reduce the bowel gas. Bowel preparation is necessary to reduce the bowel gas pattern, which may obscure the region of the interest. The routine administration of the bowel preparation use makes the examination more unpleasant for the patients and has been shown not to improve the diagnostic quality of the examination. Nowadays, it is to be unnecessary. The technologist must check the patient chart to determine the creatinine and blood urea, BUN, nitrogen levels. Patients with elevated blood levels have greater chance of experiencing an adverse contrast media reaction. That is, normal creatinine level for the adult are 0.6 to 1.5 milligram per deciliter. Blood urea nitrogen level should range from 8 to 25 mg per deciliter, milligram per deciliter. 100 ml equals to 1 deciliter. Traditionally, fluid was restricted prior to the IVU in order to improve the opacification of the collecting system. However, it has been accepted that dehydration is associated with increased nephrotoxicity. Nowadays, dehydration is not necessary and does not improve image quality. Modern non-ionic contrast agents do not provoke an osmotic diuresis, and the degree of opacification is unlikely to be significantly altered by the dehydration. Dehydration is contraindicated in some situations. Renal failure, myeloma, infancy. If examination is to be performed on a patient who has previously had a severe contrast media reaction, consideration should be given to the administering methylprednisolone 32 mg orally 12 hour and 2 hour prior to contrast media injection. Signing informed consent form. Vein puncture is an invasive procedure that carries risk for complication, especially when contrast media is injected. Before signing the procedure, the technician must ensure that the patient is fully aware of this potential risk and has signed an informed consent form. If a child is undergoing vein puncture, the procedure should be explained to the both the child and the guardian should sign the informed consent form. Technique: venous access via the middle antecubital vein is the preferred injection site because flow is retarded in the cephalic vein as it passes the clavipectoral fossa. The gauge of the cannula or needle should allow the injection to be given rapidly as the bolus to maximize the density of the nephrogram. Upper arm or shoulder pain may be due to stasis of the contrast in vein, which may be relieved by abduction of the arm. Films: preliminary or control or escort or pilot film is taken. Supine full length AP of abdomen in inspiration, that is, according to David Saturn, preliminary post micturation plain KUB. After micturation, post micturation, preliminary plain KUB film is performed. The lower border of cassette is at the level of the symphysis pubis, and the X-ray beam is centered in the midline at the level of the iliac crest, or 1 centimeter below the line joining the iliac crest. Usually, it is a varage So according to our note, 1 centimeter below the line joining the iliac crest, because in QUB it is doing that. But according to Merrill's pocket atlas, at the level of iliac crest. Done to demonstrate bowel preparation, check exposure factors, centering, and obviously pathology, particularly location of the radiopaque stones or any radiopaque artifacts. If necessary, the position of the overlying opacities may be further demonstrated by supine AP of the renal areas in expiration. The X-ray beam is centered in the midline at the level of the lower costal margin or 35-degree posterior oblique views, side of the interest towards the film. Or tomography of the kidney at the level of the third of the epidiameter of the patient, approximately 8 to 11 centimeter. The optimal angle swing is 25 to 40 degree. The examination should not proceed until these films are reviewed by the radiologist and claimed satisfactory. Immediate film AP of the renal areas, cross kidney, David Saturn. This is exposed 10 to 14 seconds immediately after the injection. That is approximate arm to kidney time, 1 to 2 minutes according to radiopeda. It's aimed to show the nephrogram, that is the renal parenchyma opacified by the contrast medium in the renal tubules. Sonography may assist in evaluation of the renal outline or possible masses, or ultrasound if subsequently available. 5-minute film AP of renal areas, cross kidney, that is David Sutton according to, and to determine if excretion is symmetrical and is invaluable for accessing the need to modify the technique of further injection of the contrast media if there has been poor initial opacification. This film gives an initial assessment of the pathology, especially the presence or absence of obstruction before administration compression. A compression band is then applied around the patient's abdomen and the balloon position midway between the anterior superior iliac spines, that is over the ureters as they cross the pelvic brim. A variety of devices are available for this. The aim is to produce better pelvic axial distension, optimizing their visualization. Contraindication of the compression. After recent abdominal surgery, after renal trauma, if there is a large abdominal mass or aortic aneurysm, when the 5-minute film shows already distant calyces indicative of obstruction, acute painful abdomen including renal colic or tender abdomen. Compression is routinely omitted in children. In the case of renal colic, even if the patient can tolerate compression, it is best avoided because it is unlikely to contribute to the investigation and potentially may exaggerate the tendency of the acute obstruction to provoke extravasation of the urine at the furnaces. 10-minute film AP of the renal areas, that is cross kidney, according to David Sutton. There is usually adequate distension of the pelvic calyces system with opaque urine by this time. Compression is released when satisfactory demonstration of the pelvic calyces has been achieved. If the compression film is inadequate, the compression should be checked and repositioned if necessary, and a further 50 ml of contrast medium administered and repeat film taken after 5 minutes. So 15 minutes film is described by some authors, that is David Sutton instead of 10 minutes film. A release film, that is full bladder. If the 15-minute film is satisfactory, then the compression is removed and a full length film is taken immediately. 15-minute release film to offer best opportunity of demonstrating the ureter. If this film is satisfactory, the patient is asked to empty the bladder. After micturation or post-micturation film, either a full length abdominal film or a coned, that is focused view of the bladder area only, with the tube angle 15 degree caudal and center 5 cm away of the symphysis pubis. Based on the earlier finding, the aim of this film are to assess bladder impeding, to demonstrate return of dilated upper tracts with relief of the bladder pressure or drainage of the upper tracts, to aid the diagnosis of the bladder tumors, to confirm uretrovesical junction calculi, to access the residual volume of the urine, and uncommonly to demonstrate a urethral diverticulum in females. This classical series can be modified to deal with particular circumstances, to attempt to increase the sensitivity of the procedure or to reduce the radiation dose to the patient. When there is significant acute retention, usually due to calculi, there is delay in opacification of the collecting system. The delay may be considerable up to 24 hours or more. It is then necessary to perform the minimum number of additional films. The time interval between films traditionally is approximately double, with film taken at 0.5, 1, 2, 4, 16 and 24 hours as necessary. 0.5 hour means 30 minutes, then 1 hour, then 2 hours, then 4 hours, then 16 hours, then 24 hours. 1, 2, 3, 4, 5, 6, total 6 as necessary. However, in order to minimize the radiation exposure, if there is no opacification of an acutely obstructed kidney at 30 minutes, it is usually unhelpful to perform the next film before around 4 hours after contrast injection. A further maneuver to minimize radiation dose in patients with a strong clinical suspicion of ureteric colic is to omit all films after contrast until a full length 15-minute film is performed. Patients with proven or suspected ureteric calculus may require one or more follow-up IV use. Intravenous urography. These should have the minimum number of films required to answer the specific question. For example, a full-length plain and 15-minute post-contrast film may be sufficient. It is very rarely necessary to perform an IV on a pregnant patient. If it is required, the radiation exposure should be minimized. The collecting system in pregnancy are capacious and the ureter exhibit poor peristalsis. Consequently, a single full-length preliminary film and a delayed solitary full-length film around 30 to 45 minutes will be enough. Additional films: 35-degree posterior oblique of the kidney, ureter and bladder in the right or left side depending on the pathology side, for equivocal collecting system elevation or the localization of the calculi. Tomography if renal outlines are not well seen or there are confusing overlying gas in the renal areas. Prone abdomen following the release film may improve visualization of the distal ureters. Delayed film at increasing, that is doubling of the time interval up to 24 hours after injection to demonstrate the actual site of obstruction. So 0.5 double 1 double 2 double 4 double 16 double infinite, so 24 hours. Prone films: when the renal pelvis is dilated, contrast may be slow to pass into the ureter. This can be accelerated by positioning the patient prone. When the heavier contrast will run anteriorly into the ureter, often to the level of the obstruction. Simply asking the patient to sit or stand for a few minutes first may improve the result. To investigate pelvic ureteric and ureteric obstruction, as the heavy contrast laden urine will more readily gravitate to the site of the obstruction. To displace the overlying bowel gas towards the periphery, position patient lies prone after 15 minutes full film and after 4 to 5 minutes of lying prone, so that lower ureter is dependent part. Full film is taken. AP with caudal angulation. To separate the overshadows by stomach on left kidney position, AP position film kidney area with 25-degree caudal tube angulation. Erect film: if it is difficult to determine whether or not there is a small ureter calculus or an erect oblique or radiograph of the ureter, or screening the ureter in this position may be useful on rare occasion to demonstrate layering of the calculi in cysts and abscesses. Furosemide on IVU. Administration of 20 mg of furosemide, that is Lasix, intravenously after the 15 minutes film with a further film 15 minutes later. If suspected pelvic ureteric junction obstruction is being investigated, there is no evidence of this on the standard IVU. This maneuver can be performed if it may provoke hydronephrosis and pain. It is rarely necessary if the patient is to be investigated with the radionucleotide renography. Yeah, that is DTPA radiogram, as is often the case in this situation. In case of children, films are taken in 3 minutes, 15 minutes, and post-micturation after contrast media injection. And further, depending on the pathology, compression is routinely omitted in the children. That is not usually performed. Pregnancy film sequence is KUB and 15 minute full film. Various and renal colic or limited study may be performed. Preliminary films, the 20 minute full length, no compression, post-micturation full length, delayed films up to 24 hours as required to show level and cause of the obstruction. David Sutton, the classical series of the plain films are immediate 5 and 15 minute full length release and post-micturation with many potential modifications. Normal report of the IVU: control film, nephrogram, pyelogram, uretrogram, cystogram, and post-micturation film. And report impression is normal excreting both kidneys. That is the report. So what is control film? In control film, is there any opacity or not? The no radiopac calculus is not in the QV region, no fracture of bone elevation is seen. Nephrogram: both kidney have opacive height promptly and symmetrically, and they are normal in size, shape, position, and orientation. Pyelogram: pelvic calculation of both kidney are well opacive, they are normal in size, shape, no filling defect is seen. Uretrogram: both ureters are well opacive height, they are normal in course and caliber, no filling defect is seen. Cystogram: ureter bladder is well filled with contrast medium with normal shape and a smooth regular outline, no filling defect, trabeculation, diverticulation is seen. Post-vital film, PVR is not significant, impression normal existing both kidneys. What are the phases? So phases are nephrogram, pyelogram, uretrogram, and cystogram. Nephrogram 1 to 3 minutes, pyelogram 5 minutes, uretrogram 10 to 20, and cystogram 30 minutes. Alternative format for IVU report: pre-contrast, no radiopac calculation seen in the QV region, no bone lesion noted. After IV contrast, both kidney have opacive height promptly and symmetrically, they are normal in size, shape, pelvic of both kidney are well visualized and normal in size and shape, no ureters: both ureters are well opacive, well visualized and normal in caliber, no kinking, deviation, or compression is noted along the entire along their length, no filling defect is seen. Urinary bladder is well filled, smooth, and regular in outline, no indentation, diverticulation, or filling defect is seen. Post-micturation: no significant volume of residual urine is seen, impression of normal study. Urethrography: this can be performed via an ascending or descending approach. With advances in urethroscopy, these procedures are required much less than formerly. Voiding cystourethropy, that is VCU, or micturating cystourethropy, or descending urethropy, or micturating urethropy. Descending urethropy is usually a part of the micturating cystogram and is rarely indicated in adults. It is more commonly performed in the pediatric population, done to access the bladder urethra, postoperative anatomy, and micturation. The resulting images are known as urethrograms. Indication: ureteric reflex, a study of the urethra during micturation, bladder leak, post-surgery or trauma, operative evaluation of the urinary tract, urodynamic study, that is for incontinence, urinary tract infection, dysuria, dysfunction, voiding, and hydronephrosis and or hydroureter, bladder outlet obstruction, hematuria, trauma, neurogenic dysfunction of the bladder, that is dysraphism, congenital anomalies of the genitourinary tract. Online children UTI, voiding difficulties, vesicular reflux, baseline story prior to the intact surgery, post-operative evaluation of the abnormalities, trauma, the suspected anatomical abnormalities of the bladder, neck, and the urethra, that is posterior urethra for adults, functional disorder of the bladder and urethra, suspected vesico-vaginal vesicocolic fistula, suspected bladder, urethral trauma, urethral diverticula. Contraindication: acute urinary tract infection, contrast medium, high osmolar contrast material, that is Zostem or Yellowsium, 150 mg iodine per ml, with at least 200 ml of 150 strength contrast division. Equipment: fluoroscopy unit with spot film device and tilting table, video recorder for urodynamics, and bladder catheter. Patient preparation: the patient prepares the bladder prior to the examination. Preliminary image, that is cone view of the bladder. Procedure: the estimated adjusted bladder capacity can be calculated using linear equations. Less than 1 year, weight into 7 equals to capacity of the in ml. 2.5 in age in months plus 38 equals to capacity in ml. Less than 2 years age in years plus 2 into 30, and greater than 2 years age into years age divided by 2 plus 6 into 30, greater than 2 years. Non-linear equation: 4.5 into age, that is in years, whole to the power 0.40 of the years into 30 equals to capacity ml. Technique: to demonstrate vesico-ureteric reflux, this indication is almost exclusively confined to the children. Using aseptic technique, the bladder is catheterized. The bladder is filled with contrast medium using an infant feeding tube. A Foley catheter can be used for all the children that is in radioparia. Given residual urine is drained. Contrast medium, that is 150 mg iodine per ml, is slowly injected or dripped in with the patient's supine, and bladder is observed for intermittent fluoroscopy. It is important that early filling is monitored by the fluoroscopy in case the catheter is malpositioned in the distal ureter or vagina. Intermittent monitoring is also necessary to identify the transient reflux. Any reflux should be recorded. In the adults, the bladder should be adequately filled with at least 200 ml of 150 strength contrast, that is from the deposition. The catheter should not be removed until the radiologist is confident that the patient will be able to micturate. The patient does not tolerate further infusion or until no more contrast medium will drip into the bladder. Older children and adults are given a urine receiver. Males are generally used to micturating while standing, and often in the unusual situation, and can manage with a bottle. While screening is performed, the spot films taken off the urethra and bladder base. Females are provided with a special drainage receptacle that is held between the thigh, but smaller children should be allowed to pass urine into observant pads on which they can lie. Children can lie on the table, but adults will probably find it easier to micturate. While standing erect, the screening table should be positioned erect. In infants and children with a nephropathic bladder, in neuropathic bladder, micturition may be accomplished by suprapubic pressure. Imaging is performed directly anterior-posterior in females and in 45-degree oblique projection in males. Spot images are taken during micturation and any reflux is recorded. A video recording may be useful. The lower ureter is best seen in the anterior oblique position of that side. Boys should micturate in an opaque or lateral projection so that spot films can be taken or the entire urethra. Finally, a full length view of the abdomen is taken to demonstrate any undetected reflux of the contrast medium that might have occurred into the kidney and to record the post-micturition residue. Lateral views are helpful when fistulation into the rectum or vagina are suspected. Oblique views are needed when evaluating for leaks. Stress views are used for urodynamic storage. FU with full bladder for demonstration of the presence or absence of the vesico-ureteric reflux. Both obliques to demonstrate bilateral vesico-ureteric junctions. Post-vital film to check for the ureter seal. Aftercare. No special aftercare is necessary, but patient and parents of the children should be warned that dysuria, possibly leading to retention of the urine, may be rarely be experienced. In such cases, a simple and helpful children may be helped by allowing them to micturate in the warm bath. Most children will already be receiving antibiotic for this their recent urinary tract infection. The dose will usually be doubled for 3 days starting on the day prior to the procedure. The children not already on antibiotics will also usually be prescribed a 3-day course, that is often after trimethoprim. Complications: urinary tract infection, catheter trauma may lead to dysuria frequency, hematuria, and urinary retention. Complications of the bladder filling, that is perforation from the over distension, prevented by using a non-retaining catheter as well as JACs. Catheterization of the vagina or an ectopic urethral orifice. Retention of a Foley catheter. Retrograde urethrography, RTU, or ascending urethrography, essentially confined to the male. Indication: stricture, urethral trauma or pelvic trauma, retrograde only, fistula or false faucets, congenital abnormalities, diminished urinary stream, urethral diverticula, urethral obstruction, suspected urethral foreign bodies, urethral mucosal tumors. Contraindication: acute urinary retention and recent instrumentation. Contrast medium: low osmolar contrast media, 200 to 300 mg iodine per ml, 20 ml, 5 to 10 ml of 150 strength, according to David Sutton. Pre-warming: the contrast medium will help reduce the incidence of the spasm of the sphincter. Equipment: fluoroscopy unit and spot film device, Foley catheter, 8 French, 12 to 16 gauge David Sutton, and 8 French or 8 French gauge or 8 G or 2.7 millimeter. In BSMMA, 6 French feeding tube is using. Patient preparation consent: preliminary image, cone supine, posterior anterior of the bladder base and urethra. Technique: retract the foreskin and clear the tip of the penis with povidone iodine or antiseptic solution. Inject a small amount of the topical local anesthetic, that is lignocaine gel, into the urethra with a syringe. Local anesthetic helps to relax the sphincter as the patient may contract it during the procedure, thus leading to a diagnosis of the stricture. Some advocate against the use of lignocaine gel on the basis that an inadequate seal is formed and patient is in supine position. The patient is positioned in a 45-degree oblique position with the dependent hip partly flexed to provide stability and ensure the urethra is not projected over the bone, according to David Sutton. The catheter is connected to a 50 ml syringe containing contrast medium and flushed to eliminate air bubbles. Using aseptic technique, the tip of the catheter is inserted, so the balloon lies in the fossa navicularis, that is navicular fossa, that is immediately proximal to the meatus within the glands, and its balloon is inflated with 2 to 3 ml of water to anchor the catheter and occlude the meatus. Metallic adapter may be alternative to the catheter. Contact medium is introduced under the fluoroscopic control, and the metallic adapter may be contrast medium is injected under fluoroscopic control, and a steep 30 to 45 degree oblique films are taken. Contrast injected gently into the urethra under the direct screening, and spot films are taken. Gentle traction on the catheter is used to straighten the penis over the ipsilateral leg and prevent urethral overlap or for shortening from the obscuring pathology. The urethra is usually easily opacified back to the urogenital diagram, and in a minority of patients, contrast will reflux into posterior urethral and bladder. The ideal image demonstrates the entire length of the urethra with contrast beginning to fill the bladder. Usually, however, with ascending urethrography, the prostatic urethra is not demonstrated. Vigorous infusion of contrast may over distended anterior urethra with extraction of the contrast into the corpora cavernosa. Female urethrography is rarely required, virtually all urethral pathology being better demonstrated on urethrooscopy or transvaginal sonography, depending on the clinical indication. Ascending urethrography may be followed by descending micturating cystourethography to demonstrate the proximal urethra and bladder, assuming there is no contraindication to bladder catheterization. For example, false facets stricture, it may be possible to fill the bladder retrogradely via the urethral catheter if the patient is able to relax the bladder neck, thus avoid bladder catheterization. Aftercare are known. Complication due to technique: acute interaction, urethral trauma, and intravasation of the contrast medium, especially if excessive pressure is used to overcome a stricture. Retrograde urethrography or ascending urethrography, micturating cystourethography or voiding cystourethography, VCUG. Generally, RUG is carried out visualize anterior urethral abnormality and MCU for the posterior urethral abnormalities. Additionally, although the bladder is not generally the main target of the exam, as with a cystogram, MCU may be useful in the detection of bladder abnormalities and vesicular reflux. In a trauma situation, retrograde urethrography should be performed first, or MCU should not be performed first, because blindly trying to introduce a Foley catheter into the bladder in a trauma setting may lead to additional iatrogenic urethral damage. The VCUG, that is MCU, is the initial examination of choice after metoidoplasty or phalloplasty in transgender males, that is female to male.